All right, it looks like we're recording now. So what I will do is, in terms of, for the purpose of the recording, just do a bit of a brief recap. And in the interim, I'm going to attempt, now the chat is open. I'm sorry for the technical issues tonight. I haven't used this computer. I'm in my office, so I haven't used it on campus. So I haven't used this computer in a while for these meetings. All right, so let's try and share. And let's go here. All right, let's try that. All right. So to recap, for the purpose of the recording, you need to be mindful of the types of CIA, and I reviewed the fact that sometimes the warning signs of a stroke or a precursor to a major stroke are transient ischemic attacks, or TIAs, and that is really important for you to note, for you to remember what I mentioned about the signs and symptoms. So there's a TIA. The symptoms are that they occur suddenly, and they're transient, right? So they come and go. So someone might seem to kind of go off, be looking off into space, and then come back rather quickly. And that could be that they've had a TIA. They just don't last as long. They usually disappear within an hour, but can last up to 24 hours. Right? An ischemic stroke is the most common type, and a hemorrhagic stroke is the most severe. Um, so I went over also thinking about what the signs and symptoms of a stroke might be, and how to be mindful about recognizing that. And there is an acronym called FAST, FAST, which is in box 7.1 in chapter 7 of the review and study guide. And that's the early warning signs. So F is for face drooping, A is for arm weakness, S is for speech difficulty, and T is telephone 911. So these are signs and symptoms of medical emergency. An NBCOT exam question may be focused on recognizing that you're working with a client and they're exhibiting these kinds of symptoms. And you would want to be sure that the best course of action would be call for medical assistance or dial 911. I also talked a bit about really kind of knowing right versus left-sided CVA. And this goes beyond the idea of, oh, I know what that is. If I have a right CVA, I'm going to have left-sided weakness or left-sided hemiplegia. And, to kind of, and vice versa for left-sided brain injury and right-sided visible symptomology. But really looking at this table 7.3 to think about what is on the left side of the brain. So going back to neuro and knowing some structures, I always think of left language, because that's where Broca and Wernicke's areas are. So here we're thinking about aphasia, either expressive or receptive, the ability, obviously, to process auditory information, being able to respond verbally, right? Two different pathways, thinking about that. There could be visual issues related to the right field. So when we think about hemianopsia, we could be thinking of that. And again, I always connected to the idea of hemiplegia or hemiparesis. I always think about sensory processing issues, right? If I have decreased ability to have sensation, then that's going to affect sensory motor on both sides. When I think about right hemisphere, I think about reasoning. I think about emotional ability. I think about processing issues. I think about emotional regulation or lability. I mentioned that. I think about executive functioning and judgment. I also think about praxis. So I think that that is pretty much what I said prior to. Did I leave anything out? If there is, please let me know. I cannot see the chat when when my presentation is like this. Let me see if I, hang on. For whatever reason. All right, I'm just going to keep going. Please unmute yourself if there's a question. Because the way that this presentation is set up, I cannot see the now I can. Okay, we're good. Again, apologies for the technical difficulties tonight. For TBI or traumatic brain injury, we're also thinking about right versus left side if that we're thinking about trauma to one side of the head or the other. There could be blunt force trauma to the front, right? To the frontal lobe, to the occiput, right? So we're going back and thinking about what are those structures, and what do they control and what does that mean? Go back also for traumatic brain injury and look at concussion protocols. They're becoming more prevalent just in terms of awareness of what repeated mini trauma to the brain is. So for concussion, you must know information is your coma scales, right? So the Glasgow and the Ranchos Los Amigos. Please make sure that you are studying those and understand. There's no simple way to say this, but you have to pretty much memorize at least one or two characteristics of each of the stages of the coma scales. So the Glasgow coma scale to me has to do a lot with awareness. So there's eye response, there's verbal response, and there's motor response, right? So when does the person open their eyes? When are they visually tracking? Are they oriented? Do they understand verbal input? Are they speaking random words or are they speaking sentences? And again, it goes from, it's the way that the chart is set up. One is the lowest functional level, and then depending upon each of these categories, it could go up to 6. So for motor, it goes from 1 to 6, and the person is able to, move on command is the highest level, as opposed to no motor response is the lowest. The Ranchos Los Amigos scale is much more detailed. Each of the levels, again, has to do with state of arousal and response to stimuli. So from level 1, which is no response or total assist, it goes all the way up to level 10, which they're saying is modified independent. So that means that the person may be independent, but require adaptive equipment or compensatory strategies. So those tables are in chapter 7 as well, right? So in terms of the coma scales, that is an evaluation tool, right? That is utilized. And occupational therapy can play a part in, excuse me, in almost all of the levels, right? So we think about a LOL, a client who is just emerging from coma or may be starting to show a little bit of response. What we might do is a multisensory approach, right? And thinking about what that is, as opposed to when the client is responding to commands, is able to engage, is capable of learning. So I always think about where is the line where we do to, as opposed to do with, or have the client do. So that idea of going from dependent to being more independent. Same principle applies, throughout the OT process. There is information about concussion in chapter 7 as well, which is in the TBI section of that chapter. Okay. All right, let's switch a little bit and talk about some intervention strategies, evaluations, and interventions. So there are the motor learning and motor control principles, which are the task-oriented approaches to motor control, and really taking a look at what that means. What is motor control and motor learning in their most contemporary sense? And what does it mean to encourage a client to engage in movement and be able to perform that movement within an occupation-based context and within be able then to generalize that movement to other contexts. So this is a really global kind of approach where it's not just about the hemiparetic or the hemiplegic side being involved in movement. It's purposeful movement, it's client-directed movement, it is movement that occurs within a context, and it has a component of cognitive learning and being able to then take those movements and generalize them to other contexts, right? So there's a whole lot of there's a table 12.1 and 12.2, which are really, really nice. It's about, that feedback loop. So this is the most contemporary approach. And for someone who has been practicing OT for a long time, I'm NDT trained. So when I look at motor learning, I'm seeing the thread of NDT get pulled through. I'm seeing threads of sensory processing getting pulled through. So this is now a practice model that has taken into consideration many of the traditional sensory motor approaches and put it together in a way that has really formed evidence-based practice related to occupational therapy evaluation and intervention for neurophysiological disorders. So it's really important that you study this, but don't forget about those traditional sensory motor approaches. They still come up on the exam. And I guess that's because the NBCOT exam bases their questions on what people are practicing. So there may be people who are still practicing using PNF, right? Proprioceptive neuromuscular facilitation, who are looking at Rude's kind of brushing and stimulating and incorporating that into practice. I think also that it's really important to have an understanding of those, what we're calling traditional sensory motor approaches, because the foundations of those are brought through into motor learning principles in one way or another. The key with motor learning and motor control is that task oriented, it's occupation based. The person is not just moving for the sake of moving. So when I think of, doing PNF diagonals, it's not just about performing the diagonal. It's about incorporating that movement pattern into some kind of functional task, into occupation. So basically that is pretty much things in a nutshell. Evaluations are going to vary from site to site. Obviously, we're looking at motor control. We're thinking about muscle tone and the influence of hypotonicity on the ability of the client to move. We might look at if there are reflexes present. So when I study CVA, or when I tell the students about studying CVA, I wrap cerebral palsy into that also, because these concepts also apply there. So make sure that you're also taking a look at orthotics. What kinds of orthoses might be recommended? Are we looking at preventing contracture? Are we looking at functional support of a hypotonic hand, so that we don't lose arches of the hand? Are we looking at physical agent modalities to decrease edema? So bring in some of that. You may see questions related to the use of slings, and orthoses related to CVA and TBI. And the other thing that is not really included so much in this particular office hour, but also be thinking about if there's difficulty swallowing, if there's dysphagia. If someone has facial droop and that continues, what does that do to thinking about dysarthria, thinking about management of food? So I just wanted to throw that in there. There is another, excuse me, there is another office hour that's delegated more or less to oral motor dysfunction. So I just wanted to kind of give you an overview. I hope that that was helpful and it kind of can stimulate some conversation. I'm just going to go over the exam item of the week. So a middle cerebral artery stroke is the most common kind of stroke. That's where most strokes happen. This client is having difficulty brushing their teeth and hair due to ideomotor apraxia. So you need to know the different kinds of apraxia. Ideational ideomotor dyspraxia, what that means. And the goal is to groom independently. So what is the best intervention approach for this client? Is it provide hand over hand guidance? Is it demonstrate the task prior to its initiation, give verbal instructions, or put everything in front of the client so they get the idea that they're supposed to be grooming? And the answer is hand over hand. So this again takes into consideration that a person with ideomotor apraxia will need assistance to initiate and complete a motor task. It also incorporates the principles of task-oriented motor control and motor learning. So this again is a multisensory approach, right? We're also, it says tactile and kinesthetic. We're also providing a visual there because the client is going to be following those movements. Okay. So that exam item of the week is, as all, are published on Thursdays. The answer is provided on Sunday, and then the office hour on Tuesday follows. So you can follow Therapy Ed on Facebook, Instagram, and it shouldn't say Twitter, it should say X, I guess. We'll have to update that. So I'm going to open up the floor for questions. I'm going to stop my share and